A few years ago, while I was attending on the inpatient cardiology service, the medical student on the team approached me and asked whether I thought he should do cardiology or primary care. Without hesitating, I said something like, "When was the last time you talked to a happy primary care doctor?" When I felt bad after about having been so dismissive of primary care, I thought the issue was just that he had surprised me at a busy, distracted moment as I was rushing off to see a patient. And in another attempt to justify my reaction, I told myself that I was looking out for his best interests. A lot of primary care doctors are unhappy. But as I was reporting on primary care, so many trainees and PCPs told me that not only had they been discouraged from doing primary care, but also that they were told that they're too smart for it. And at some point, after hearing so many versions of this same story, I realized that my hasty dismissal of primary care probably reflected a value system I had long ago internalized. For reasons I'm still trying to understand, a lot of us who don't practice primary care seem to think it's beneath us, not a suitable career path for the best and brightest trainees. And so the question is, why? I'm honestly not sure I can answer that question. But if we want primary care to survive, I think it's really important to understand how this value system plays out in the daily lives of both students and practicing clinicians. My goal in this episode is not to lecture people. If some of us are telling students that they're too smart for primary care, that advice probably reflects a feeling, and you don't change the way people feel by scolding them. But I definitely think it's worth thinking about why the people among us who are responsible for knowing the most are often valued the least. Some may argue that the modern-day constraints of primary care feed this perception, meaning it's become harder for primary care doctors to practice comprehensively. So maybe we appreciate the breadth of knowledge and skill set less. But it's also critical to recognize that this denigration of primary care isn't new. One prominent family physician told me that when he was ranking residency programs in 1973, the chair of internal medicine at his medical school sat him down and told him that he was wasting his entire medical education by going into family medicine. He ignored his chair and has had a deeply gratifying career. But for many of us, it's hard to resist the cultural forces telling us where prestige lies. And most of us learn pretty early on that it's not primary care. I'm Lisa Rosenbaum, and this is Not Otherwise Specified from the New England Journal of Medicine. Our first guest is a first-year medical student who asked to remain anonymous, so I'm going to call her C. C went into medical school fiercely committed to a career in primary care. And when I texted her soon after classes started to see how she was doing, C told me that only 8 weeks into medical school, she was already exhausted by having to defend her primary care career ambitions. Though C spent 4 years between college and medical school, getting a master's in public health and doing some policy work, she was really drawn to the clinical setting. So I asked her why, specifically primary care.
It was those 4 years that I took after graduating undergrad, and specifically, I spent 3 months in the Mississippi Delta, and I was rotating with an OB-GYN and a pediatrician that work in a health provider shortage area, and seeing them day to day being truly heroes. It was just practicing cowboy medicine, essentially, where they are the first point of contact for everything from immunizations to someone actively hemorrhaging. It was amazing to see that level of responsibility, but also that level of trust from the community for that one person.
With her primary care aspirations in mind, I asked C what medical school had been like for her so far, and I specifically wanted to get a sense of what her peers thought about her ambitions. C talked about being in anatomy lab that morning.
I was putting my finger through the inferior vena cava and finding my way to the superior vena cava of the cow's heart. And one of my classmates was like, "Oh, you just have such a way." He's also in my anatomy group, which is our cadaver dissection group. And he's like, "I just can't believe that you want to do primary care. Like, you're too smart for that." And it was so funny because I knew that we were going to be talking later today. And I was like, this has to be a stroke of whatever. And I was like, you know what? I want to ask him why. And I was like, oh, why do you think that? I think that primary care physicians have to do a lot. It's a juggling act. It's a balancing act. You're handling a lot of volume. And he was like, well, I just don't understand. It seems like your skill set lies like in a very technical, specialized way. Why wouldn't you pursue that? And I was like, I think that we came to medical school for different reasons, is what I said to him. I don't think he really liked that, and but we're going to have to follow up on that. But yeah, the long and short of it is that I think that people realize just how much effort it takes to even get to this position of getting into medical school, because it is just so hard right now to get here. And then thinking about all the work that has to happen after you're here. For some reason, there's some notion that you'd be taking the easy way out if you chose to do a primary care non-technical specialty, and that if you are smart, that you are not realizing your potential by pursuing that path. And by not realizing your potential, you're not actually the best doctor you could be. And so it's just this undertone. And so my friends who are not in this primary care leadership track with me, they're always like, I'm going to be a primary care neuro-orthopedic surgeon, because they're like, yo, you're just going into primary care just for giggles, but you're actually going to be specialized in like all of these different things. And they're like, yeah, we'll see you 3.5 years from now at match day, and you're going to open that letter and it's going to be like plastic surgery. Like, it's just, yeah. So it has been a bit of an uphill battle to try and justify and try to explain my interests and passions. But I don't blame my classmates, and I feel like because I had 4 years to really understand what part of the medical system I want to insert myself in, I really feel that my convictions won't be shaken by the environment.
It's very interesting to me that even 8 weeks in, like, you are already facing this acculturation, which, as you've described it, and I would then summarize, is some diminishment of primary care that also, as you said, you don't really understand, and I don't understand it either. And I think you might be too humble to point this out, but when you say that your friends are saying you're going to be a primary care, like orthopedic neurosurgeon or whatever, the implication is they see something in you, right? They see that you either have technical skills or some sort of superior talent, intelligence, whatever it is. So, like, why would you do primary care? Is that a correct assessment of that dynamic? Like, why are they saying that to you? What about you makes them think you should do this other thing?
So I know I mentioned like the technical prowess. I also think that it's some sort of confidence. I think it's a confidence thing too, where if people look at you and they're like, oh, she's competent, and she knows that she is competent and doesn't feel the need to prove herself, then yes, she should be doing the hardest thing. But I do think that there might be a misalignment of what the hardest problem is. Because in their mind, the hardest problem is neurosurgery. The hardest problem is orthopedic surgery. The hardest problem is doing craniofacial redevelopment for XYZ. But in my mind, the hardest problem is access to care, is access to a physician, is just access to health insurance. That we have different ideas of what is hard and what needs to be solved. And because they may not have had exposure to that hard question, the default is if there's a competent person, they should be solving what they think is the hardest thing or be doing the hardest thing.
But why do they think primary care is easy?
Because nobody rotates through a primary care clinic. Nobody shadows a primary care physician when they're trying to get into medical school. People shadow the dermatologist. They shadow the hemonc doctor. They shadow for lack of better words, the sexy specialties, because that's what you get in major academic teaching hospitals and these prestigious universities from which all these students come from. I haven't met a student here yet who is like, oh yeah, I was shadowing with a primary care doctor for 5 hours this morning. It'll be like, oh, I was with an ophthalmologist and we were doing a retinal detachment surgery, and it's very procedural, right? And so it's a lot more fun to watch, and to be a part of. I think it's an exposure thing.
Interesting. And do you get this from professors as well, or is it right now all from your peers?
I want to say and there's a difference between what I want to say and what I've experienced. I want to say that because I'm in this primary care leadership track, that I've had exposure to more primary care physicians and that I feel very supported by them, but I haven't yet. And so what I will say that I have experienced in the first 8 weeks of medical school is that all of our professors are specialists. All of the mentorship that we receive, whether like my POCUS leader today was an emergency medicine doctor. The previous session was an interventional cardiologist. I haven't had much teaching experience from primary care physicians thus far. So I don't know whether institutionally they're trying to shift us away from primary care, but I will say again, this is a large teaching hospital. And so the top doctors are specialists just because this is where people come to receive specialty care.
Whether academic institutions are deliberately steering their students away from primary care or are simply blind to the lack of primary care exposure, I don't know. But I think for those actually practicing primary care, the sense of institutional neglect is hardly subtle, meaning many institutions make pretty clear to their primary care clinicians that they're not valuable. Mark Friedberg is currently Senior Vice President for Performance Measurement and Improvement for Blue Cross Blue Shield of Massachusetts. But prior to this role, Mark practiced primary care for roughly 20 years at an academic institution and also did a bunch of research that took him to primary care clinics all over the country. So I started by asking Mark how the research helped him understand how primary care was valued or not valued within any given system.
So these were studies that I did at RAND along with a bunch of colleagues that were actually sponsored by the American Medical Association, which was a really great partner in this research. So it was 3 studies. The first one had to do explicitly with professional satisfaction, and that was published in 2013. And it was factors affecting professional satisfaction. And we were like one of the first studies to really talk about how the electronic health record was actually a real problem for physicians and a major dissatisfier. And I think that's only intensified over time. But during that study, and we did all these studies by visiting doctors in practices all over the country. These were like a lot of on-site interviews, so got to see a lot of different offices. The second 2 studies had to do with payment, alternative forms of payment, new payment models and how they affected physicians and their practices. And sometimes we were talking to doctors in independent practices that were off on their own. Sometimes they were independent but part of like an IPA, so an independent practice association where they had sort of an administrative structure, and some that were in more sort of employed big systems. And it dawned on me by maybe midway through the second study that, first off, how the systems got paid had not very much to do with how the internal doctors got paid. So the system might have all kinds of pay for performance or shared savings or capitation, but it was still paying basically fee for service internally based on RVUs. And so that was already systematically sort of perpetuating differences in compensation between those who do and don't do procedures. But also, sometimes the payment models, we would talk to the payers, were very explicitly trying to improve reimbursement for primary care. And it just wouldn't make its way to the physicians or their practices. And you would realize this because you'd go into these primary care practices and like there's duct tape everywhere on the furniture holding it up or like on the examining table. And I started asking 2 questions to the PCPs and the specialists in these organizations, really just to get a sense of where things actually stood. The first question was, where did you get your furniture? And I remember this one practice was like, oh, I'm so glad you asked. We got this great new furniture that we found in the street when the orthopedic practice got new furniture and they put theirs out on the street and we got it. And so I was like, wow, what a great answer. Now I know, now you know the pecking order, right? And yet the second question was, when you lose a really good nurse or medical assistant, where do they go? And if the answer is, oh, to the orthopedic practice or to the cardiac surgery practice or the cardiology practice or the oncology practice, one of these other much more well-reimbursed practices, you know that the flow of talent is moving away from primary care in a way that's really destructive to the primary care practice. They spend all this time training these folks, sometimes straight out of school. And just when they get them to a point where they're like really good and adding a ton of value to the practice, they leave for a better paid job. I don't blame them. In the subspecialty practice within the same organization much of the time. And so it's really corrosive to the primary care practice to keep having to deal with competition within its own organization. It's just really unfair. They have to be, sadly very grateful for cast-off furniture. That's tough.
Another thing that I think I've seen you like even tweet about at some point long ago, but that we in medicine, I as a cardiologist, we dump on primary care doctors. I do this all the time. Like when I discharge people and they have something and I don't want to deal with it, I don't know what it is, I say follow up, can you just ask your primary care doctor? That happens all the time. Or like, I started doing an ACE inhibitor. Can you just have your primary care doctor check your labs in a week? And I'm curious if you experienced that dynamic and if you could tell us a little bit about that, because I don't think there's anything inevitable about that type of intraprofessional interaction.
Yeah, and I don't think it's even intentional, honestly. I think it's just kind of natural. It's like a part of the culture. But I think you've definitely put your finger on something that is tough about primary care, this idea that you're always at the bottom of the totem pole. And this happens in so many different ways. So one example, and I just don't know if hospital administrators know how destructive this can be, is to tell the PCPs, we're subsidizing you. You're takers. The orthopedic surgeons are the makers. And how dare you ask for more resources? We're already paying more than you're worth. And these, by the way, in many cases, are PCPs who were bought by the system, and the system paid some money for their practice. So it was a going concern. They weren't losing money. It's just that what happened is all of a sudden, all the ancillaries that PCP was doing that actually generated some margin are now in some other cost center, right? So the maker-taker thing is very corrosive. A. But also beyond all that, and beyond the furniture issues, and beyond the MAs, the really talented ones being moved over to the higher paid jobs in the specialty clinics, is this idea that implicitly the PCP works for me if I'm the surgeon. So the place where this kind of bothered me the most was preoperative exams, especially unnecessary ones, like for cataract surgery. Like no one ever needs a pre-op exam for cataract surgery. It's about as cardiovascular demanding as having a pedicure. And you'd get this like fax from somebody in like an ophthalmologist office saying, your patient's having their cataract surgery in 2 weeks. See them or their surgery's canceled and I've told them that and they'll be mad at you. I'm like, my clinic is full. This is like a visit that doesn't even have to happen at all. And you're asking me to displace somebody who actually should be seeing me, or for me to like see people for shorter periods of time, double book, do all the stuff that really annoys people when they're like wondering why their physician's late because they're doing some unnecessary pre-op cataract exam and filling out some paperwork and maybe even being demanded to do a chest x-ray and an EKG, or at least an EKG, which you definitely don't need to do. There's actually an RCT on this. And then being kind of yelled at by, for a while, I just did these things and I was like, I read the literature and I was like, I don't need to do these things. NEJM had a paper, Shine et al., RCT actually, about cardiac pre-ops, totally unnecessary for cataract surgery. So I would sometimes, I guess, cheekishly like print out the article and fax it back to their office. And then I'd get some angry scrawl around that, come back to me. And at some point, I just started calling these folks. I said, like, why are you asking me to do this exam? They said, well, Dr. So-and-so says, I never get to talk to the ophthalmologist, right? It's somebody at their office. So I hold for the doctor. I talk to them and they say, well, actually, I know it's not necessary. Sorry, you got me. But the anesthesiologists require it. Like, oh, well, let me talk to the anesthesiologist. So I call up the anesthesiologist. And the anesthesiologist is like, yeah, we know it's not necessary, but the OR committee requires it. So I talked to the chair of the OR committee. I only did this like once because this took a lot of effort on my part. So both the ophthalmologists and the anesthesiologist know this isn't really necessary. So why does the OR committee require it? And they're like, oh, it's because Medicare requires it. Like, what? Medicare? I was doing this in the mid-2010s. And it turns out this was their interpretation of a certain regulation, which was that if you're going to do a surgery in an ambulatory surgical center, which is totally appropriate for, you don't need a big hospital for a cataract surgery, you must do a comprehensive examination within some period of time. I think it was like 30 days before the surgery. The surgery doesn't get paid, right? And I was like, oh, well, why didn't the ophthalmologist do it? Peals of laughter on the other. I mean, like no one could even imagine the ophthalmologist doing this comprehensive physical exam, right? That's not what they do. So, of course, now this is getting dumped on the PCP, but the way it's being done is instead of like, boy, I'm so sorry you have to do this unnecessary exam that Medicare makes you do, but like, could you work it in when it's convenient, Mark? Like, that would be really great. I know it's not important. My schedule's totally flexible. Just do it when you can get to it. No, it's not that. It's this surgery's happening in 2 weeks. Implicitly, you work for me or you're a bad doctor, do this exam. And that's hard. That's grating. And this is just one example of all that. I'll say one other example of all this that is just really tricky. I don't think this is all doctor on doctor stuff. This is kind of like society on PCP violence, which is like disability forms, right? Like disability forms. Have you seen one of these things? They're filling these things out. It's bizarre. You're being asked these incredibly detailed questions, like how many pounds can this person lift with their right arm? How about their left arm? How long can they sit in minutes per day? How about standing? How about kneeling? Can they crouch? How many visits are they going to need with which specialists over the next year? And is this going to be a relapsing condition? How long do you think it'll take, Mark, for this to get better? And it's in a bunch of unanswerable questions, but you can't actually turn in an incomplete form. And this gets dumped on you. And there's no payment for any of this. This is like an immense amount of work to fill this out. So the best you can do, I think, as a PCP is you either just do your best guess as to like what you think, or you call up the patient and be like, okay, what, can you crouch? Can you sit? Like, how bad are you hurt? And you fill it out. But this takes a lot of time to get that done. That stuff just always ends up on the PCP, not the surgeon who operated on their back, let's say, or anybody else. And I'm not saying the surgeon should do it. I'm just saying no one should do this. The idea that a doctor needs to be involved in any of this is nuts. What I understand of other developed countries is that they don't actually make all social welfare programs go through the medical system, which puts the PCPs in this real bind and wastes a ton of time and is very burnout inducing.
Rerouting certain aspects of our social welfare programs away from the medical system will require political interventions. But I think Mark's also getting at another dimension of our professional values, which is to say, part of the reason this work falls upon PCPs rather than any other discipline is because of some seemingly implicit understanding that PCP time is less valuable in the first place. And of course, whatever implicit sense we carry about physician worth has actually been made explicit by a reimbursement system that places more value on the procedural than the cognitive. Because this hierarchy has been around so long, I think many of us have just accepted that cognitive contributions are just inherently less valuable than other services like performing cataract surgery or replacing a knee, meaning to many of us, this ordering of physician worth seems natural. But Mark also recalled how during his own residency, he began to question whether this hierarchy is natural at all. You'll hear him mention the Relative Value Scale Update Committee, also known as the RUC, which sets the rates of physician payments. Here's Mark again.
I remember giving a talk on physician payment when I was a resident. I had just learned about the RUC. I was like, what is this craziness? I had no idea this incredibly powerful committee even existed. And I was talking to my co-residents, and one of them, Jeremy Green, who's now at Johns Hopkins, or was a history leader, and he said, well, what you're talking about is epiphenomenal naturalization. I was like, what is that? He said, well, what that is that there's an underlying reason why you have vast income differences between specialties that they start to assume it's natural. And it reflects some kind of necessary state of natural law. Like, of course, PCPs aren't paid as well. They didn't do as well on their boards, and their residencies aren't as selective. And these are the people who barely got into medical school, and on it goes. And that has nothing to do with it. It all has to do with the RBRVS system, which is done to us by Medicare and is very hard for any commercial payer to break away from, because you don't want to have to come up with your own set of CPT codes. That is very expensive to try to come up with, or your own version of the RUC internally. Again, incredible overhead expense there. So, it's very hard to diverge from those, either the codes themselves or the value that is placed on each code in terms of its financial payment. But it underlies the culture. This is where you hear, the thing that people dread, like you're too smart for primary care. Or people who are looking at the different clinics that they tour through in a hospital. They go to the resident primary care clinic, and it's not very nice. Equipment isn't there or isn't working all of the time. They go to the specialty clinic that's like in the glass tower. It's very nice, very well staffed. And they see how happy the physicians look. Maybe they know what kind of cars they drive, if they see them in the parking lot. And it's hard to ignore these things, even if income isn't explicitly discussed, right? You kind of have a sense of what kind of lifestyle you're signing up for in different specialties. And that filters all the way back into popular TV shows where you see who's like in charge. It's the surgeon, it's the emergency doctor hero. And I think that all of that is kind of, honestly, many levels up manifestation of this very deep thing that's going on with administrative pricing in the U.S. healthcare system.
We'll be talking about the RUC at length in a later episode. But first, I wanted to better understand this concept Mark alluded to of looking at the present ordering of physician worth as if it's totally natural or inevitable. So I reached out to the friend Mark mentioned, Jeremy Green, who's a history of medicine professor at Johns Hopkins. I asked Jeremy for some historical perspective on where these values come from and whether or not they can ever be changed.
As long as the biomedical endeavor has persisted in dividing up human beings into smaller parts and deriving diagnostic and therapeutic power through that force of progressive reductionism, right? There has always been a parallel concern in the opposite direction, that in chopping up the human body or the field of medicine into lots of little bits, we lose track of the whole.
Jeremy emphasized something we heard from a soft tone as well, which is that patients seem to want a physician who can tie it all together for them, and who can do that by virtue of knowing them over time. But as Jeremy notes, when this type of generalism succeeds, it's usually in spite of the system, not because of it. What both Mark and Jeremy suggested, however, is that this devaluing of generalism doesn't need to be accepted as natural or inevitable. And to make this point, Jeremy pointed to other countries where the income disparities between specialists and generalists are much smaller.
So while we may not be able to do away with the intrinsically hierarchical basis of how we even conceptualize primary care within the US healthcare system, we can look at other countries, other systems that actually do work to minimize the distance in status, in income, and in overall regard between the subspecialist and the primary care physician, right? We don't need to accept that as an absolute. The degree to which we've actually produced these disparities in US healthcare is like no other country in the world.
I appreciate, intellectually, this idea the historical perspective offers, that there's nothing natural or inevitable about our professional hierarchy. But as much as my brain likes to think about this concept, and for whatever reason I really like the phrase Mark used, epiphenomenal naturalization, we're still left with this reality, not just that we devalue primary care, but that our values are so emotional. I can tell you there's nothing natural about primary care's position at the bottom. I can also tell you it's just epiphenomenal naturalization. But does it make you feel differently? Does it make you want to stop dumping on primary care? I'm not sure whether recognizing the process of epiphenomenal naturalization makes me any less likely to turf disability paperwork to primary care in the future. But something that did make me feel differently, at least a little bit, was listening to the medical student C. Not just her passion, though that helps, but the way she described how backwards our priorities can be when it comes to valuing hyper-specialized expertise over generalism. Her description really resonated with me emotionally.
I am happy to be on the path that I want to be, that I know is a part of the impact that I want to make. But it does feel incredibly divorced from, as I was kind of alluding to before, the problems that I care about. Because I feel that I can't discuss any of these patient-facing issues with my peers because we're so in the weeds, because we're so focused on the technical aspects of medicine. And those are incredibly important, please don't get me wrong. I just think that becoming a good doctor is more than being a good student. And I feel that the earlier we are to introduce those concepts, the better care we'd be able to provide. And I do think it would solve many problems with that one paradigm shift, i.e. people not understanding that primary care might be a hard problem to solve, if we were to introduce the patient's problems first. Because the thing that frustrates me and the thing that I get really upset by, those are the same things, but I'm sitting there in lecture and we're talking about really complicated procedures or genetic testing or this reserve that our university has of the entire human genome and how patients can have access to that and whatever. And I am like, can we take 500 steps back? And can we talk about how on my way to class today, I met a patient in the parking lot who had been circling the hospital building for the past 40 minutes because they couldn't find where their doctor's office was. Because we have created a medical complex with so many barriers to entry that the patient can't actually get where they need to get to receive this world-class care that we keep talking about. And I don't know whether that's another issue you need to place on physicians in training or doctors, but I do think that it's an important issue to have front and center, because maybe the person wouldn't develop cardiovascular disease if they'd seen you 20 years prior and you'd been able to talk to them about the effects of XYZ.
What did you do for the patient?
Oh, I walked them to their patient appointment. And I was 5 minutes late to class because it doesn't make any sense. Like, we're just not, I don't think We are always solving for the lowest hanging fruit.
When C was talking, I was trying to imagine whether, had we been classmates, I would be motivated by her passion for solving these other problems or annoyed by it. And part of why I wasn't sure is because when we first met, we butted heads a little over whether the healthcare system is responsible for addressing social problems. Okay, I'll confess, like when we met, we had a discussion about, I think, like access to nutrition maybe, or something like that, where I was like, whatever, that's not our responsibility. And you're like, yes, it is. And I was like, oh, she's going to hate me. She's definitely going to hate me. And so I guess what I'm trying to get at is it's really hard when you are so passionate about something and you have a sense that what you care about is moral, perhaps more moral. How do you like not alienate people by being righteous? And I don't think you are. Like the reason I'm comfortable saying this is because I sense in you such a genuine commitment to this work. But it is so hard when you are around people who you feel like aren't seeing it to like not be righteous about it. Do you know what I mean?
Yeah, I know exactly what you mean. Because this is something I think about all the time. And what ends up happening in reality is that I can't share most of these passions with my classmates and with my peers. And it's not their fault. It's just I'm a little bit older and I just think about things a little differently. But when I do talk about it, I actually do think that they are quite receptive. They're like, oh, we didn't know that you'd done this. Like, oh, like that's so cool. Tell us a little bit more. But the not seeming righteous part, I think that we've reached a point in our society where a lot of these things are being taken away, a lot of these avenues for caring about people who are underserved, people who are in rural areas of the country, people who do depend on public services, all these things are under attack. So I don't even know if it's righteous anymore so much as this is current news. Like these are things that are actively being impacted and hurt by decisions that we're making as a country. So I think I'm actually just talking about current headlines at this point. So I think that it plays it safe to not have to care about these things in medicine because you were talking about the moral imperative, right? I think that most people come to medical school because they want to do good. And objectively, you can do good by being a dermatologist, by being a plastic surgeon, by being a procedure-based physician. It is harder to do good when you see a patient consistently. They have many problems, including housing instability, food instability, transportation issues. They can't pay for their medications. Oh, and by the way, they don't have health insurance. And also they have 3 children that they have never brought into the pediatrician. I think it's much harder to objectively feel you are doing good when you cannot address all those problems. And so I don't mean to fault, again, my classmates or my future colleagues, but I think it makes it easier to go to bed at night when you are not responsible for so many complex issues, which being a primary care physician puts you at the face of.
I do think culture can be changed. I mean, the only reason I'm paying attention to this is because culture changes all the time. And this feels like a point that we could really shift within our educational environments. We could do a much better job of valuing primary care amongst ourselves.
You know, part of me thinks that it's actually the solution to a lot of the issues that we have around, to name like anti-vax or any of sort of like the misunderstandings of things in science. All of these things are based off of relationships with people and communities and access to that information as early as possible. And I almost feel like if we were to frame primary care as the important touch point that unites us, it could be another sort of push for that.
I deeply agree with C on this point. And in fact, in the 5th essay I wrote about primary care, which comes out this week, I touch upon this very notion that as complex and multifactorial as distrust of science and expertise may be, our complete failure to support longstanding relationships between patients and their PCPs has understandably left many patients seeking answers elsewhere. Patients, however, aren't alone in getting so frustrated that they turn away from our healthcare system. primary care doctors, too, can only take so much.
So more doctors leave, so the doctors who are left are just overworked that much more, and so more doctors leave, and so it's never going to end well, right? I just don't believe it. I'm sorry.
That's next up on Not Otherwise Specified from the New England Journal of Medicine. I'm Lisa Rosenbaum. Our editor is Debbie Molina. Our producer is Mary Rose Madden. And Adam Strauss is our audio engineer. Blue Dot Sessions supplied our music. And I also really want to thank all of my colleagues at the Smith Center for Outcomes Research at Beth Israel Deaconess Medical Center. They've helped me conceptualize this season and identify the most pressing and unexplored challenges facing primary care. My new article series on primary care can be found at NEJM.org.